probably make a start now. So welcome everyone to this session on patient access to online records. So by way of introduction, my name's Osman Bhatti. I'm a GP in North East London and the CCO for North East London ICB. And this is basically an update on where we are currently. And the way I'm going to do this is by doing a presentation on where we are and some recommendations for practices. And then following that, what I'm hoping to do is just have a space for some questions and answers at the end. And this is being recorded as well. So if anybody wants to access this in future, they can do. And the other thing I've done, I've just everything I'm talking about, I've done a short blog about as well, and I'll share the link to that blog. So you can share this with colleagues, and I'll add this webinar recording to that blog at the end as well. But feel free to enter in questions as we go along, and I'll pick those up, or comments as we go along, and I'll pick those up towards the end. Okay, so just to kick off, where are we at the moment? And this is just a bit of a stock take as to what's going on at the moment. And on the 1st of November last year, this was when the big switch on was supposed to happen, and there was a lot of debate flying around, a lot of confusion, to be honest. But what happened was that 20% of GP practices got enabled for prospective access, and therefore 80% didn't get enabled. So that's essentially where we were on the 1st of November. Now, at that time, some practices asked EMIS and their system suppliers, TPP, to not enable automatic access to prospective access to patients, and also some practices had coded some or all of their patients to prevent the automatic prospective access from occurring. Now, if I have a look back at the contractual obligations, and this is all linked up here as well, that you can read at your own perusal. But generally speaking, that there was a set of contractual requirements for access to prospective medical records that was visible in November, towards the end of last year. And since then, there's been a whole host of things that have happened nationally. And as most of you know, NHS England have also started to impose a contract. And as part of that imposition, what I was quite surprised to see, and I hope the BMA have picked up on this as well, is the fact that they updated the contractual requirements for prospective access and effectively moved the goalposts quite a lot, in my opinion, and haven't really publicised this to GP practices. And I think it'll be quite good to actually get people to be aware of some of these things. So I'm just going to highlight a few things in here that I've picked up, really. So some of the things that they've highlighted are things around the fact that actually, rather than practices must promote an offer, they've just changed wording subtly to say that they must do. So rather than giving practices some autonomy, it's changed the contractual wording to really force practices to do a change, which I think our union will be quite interested to look at in future. But I think this is something that's out of our scope at the moment, but just to reference what is happening. And there's also subtle changes that they've made. So some of the amendments they've made is here they've taken out reference to redaction software that was in regulations back in 2020. And also there's stuff around consideration that as contractors, as GP practices, if we felt that this was having a impact on the practices running and providing the essential services, there was a facility to basically say, look, we're too busy for the moment, we will implement this, but when we have sufficient capacity to do so. And in the contractual imposition, they've basically removed that completely. So they haven't given any leeway to practices at all. And if we look at other parts of legislation that's come through, what they've done is that they've totally removed any mention of redaction software. So I think my main point here is to highlight the fact that actually there's been lots of changes that have happened contractually that hasn't been communicated to practices effectively, and I think that's going to cause problems further down the line. I think we just need to be aware of that as practices. So I think the thing to say, where are we now. And I think as predominantly in North East London, we are virtually all EMIS, and what we've noticed is that EMIS have written to every single GP practice. TPP haven't done this as yet. And what EMIS have said is that all GP practices need to sign up to release their records for prospective access. And the next phase of releasing prospective access is happening tomorrow. So tomorrow, they're going to enable anybody who's signed up to release the records to be enabled. And if any practice hasn't enabled that, then they've said that on the 31st of October, there'll be a contractual enforcement that will occur. What that contractual enforcement is going to be, I'm not sure. I think this is something that the BMA have also taken up and are going to be discussing, and I would hope the RCGP would as well. So there is the
Dr. Bhatti, you're muted.
Sorry, it's
Yeah. You were muted.
How long have I been muted for? Somebody
I think just a few seconds.
Just a few sentences.
There are some people struggling with sound,
brilliant.
but I think for the most part, everyone is kind of here.
Fine, brilliant. Okay, so basically, yeah, I'll just reinforce the fact that there will be a contractual enforcement on the 31st of October, and we don't know quite what that will involve, but the BMA RCGP are or should be taking this up with NHS England as to what this will be. But it does leave practices in the middle, and I think because the goalposts have moved, we need to really think about what we are going to be doing. Now, this is the email that most of you have received with a confirmation that practices have to sign. Going to, if you click through the link, you have to agree to two things: that you've understood the readiness checklist and the EMIS guidance, and confirm that automatic prospective record access has been clicked. And I think we just need to be careful and just take a step back and look at actually what is it that we are committing to, because essentially there's some handover of responsibility to practices by checking these boxes. So they've made it very easy to click, but implications, in my opinion, are quite big. So if we have a look at the first thing, this is the readiness checklist, and I'm just going to bring this up now. So this is the readiness checklist that has been circulated as one of the things you've got to agree to, and effectively policies and processes. So all practices prior to switch on must be doing all of this, and I think this is going to have an impact on practices. So reviewing your clinical systems and setting up the global settings, I'll come on to that in a bit. Looking at all your policies, looking at processes about confidential information. Anybody who's at risk of serious harm, you've basically essentially excluded them by doing some searches, which again I'll come on to in a bit. Looking at patients who are turning 16, and managing patients who want to change anything in their record, and ensure that information is now entered legibly and accurately, and review the learnings from the early adopter sites. So there's quite a lot, some of which is relatively straightforward and we should have been doing, but there's some in there that's going to increase the workload in the practice. And the other thing about training, so practices have to make sure that everybody, including locums, know how to redact, identify risk patients, and know how to write the notes adequately, and that all patients are familiar with the changes in the process and identifying at-risk patients. And then there's some other things further down around what people will be able to see. So appointing a digital champion in your practice, or lead, who will be able to promote this, and advertising it generally. So there's quite a lot that practices have to agree to in that simple little checkbox. By ticking that first box, you're basically saying you've understood all of those conditions, which I think is quite challenging. And the other point I'd just like to review is the other part of this, which is mentioned in the readiness checklist, which I'll just reference just quickly here. They've referenced the additional resources that are available here, and on the first page, here we go. There is a clinical safety case report available to support practice understanding and the associated risks and mitigations needed. And I don't think that's very clear in the documentation. So the question for me really arose locally was, who's done that clinical safety review? Is it the practices, PCNs, federations, or the ICBs? And there has been a whole lot of documentation around the mitigations that was published in September prior to the November release, and I've got a link to that information as well. So if I just click here, and so this is the whole document which I've got linked, and if I go through, jump to the recommendations on here, and you can have a look at the kind of things that NHS England are assuming practices are doing. So one of the risks is that patient will view harmful information. So practices should have a clear redaction policy, standard operating procedure, everyone knows about it, identify the vulnerable patients and add them to a separate list and regularly run reports. So this is what practices should be doing because of the risk. If the third party accesses the patient record, this is interesting. Practices must engage with vulnerable patients before going live, but it's recognised that patients may not be known to the GP who might be missed, which I thought's interesting. All patients should be made aware about third-party access, and we should be reviewing historic rules. And if the practice has a failure to provide the prospective access, that we need to be ensuring that locum agencies and our locum staff are aware of the changes. We need to review all of our processes. There's quite a lot of mitigation that's left to GP practices, and if the whole failure system fails, then practices should have a SOP which includes reporting fallback and a business process, and to report this back to the supplier. So for me, this is quite a lot of mitigation for GP practices. And I suppose one of the biggest things locally in North East London specifically is the fact that actually who has the access, because we are aware that there are quite a lot of patients who may be vulnerable. So those patients who've got mental health issues, there's domestic violence issues, is there coercion going on? Do people have any capacity issues in terms of understanding what's there? What about the sensitive diagnoses? So there's quite a lot of things that we need to really be thinking about here. So the other thing that we should be doing is running proactive searches to exclude patients, and we need to have a way of having this done in a sustainable way within our practices, and bearing in mind that all the redaction software comments have been taken out of the contract. So this is no longer what was promised in 2020 has been quietly deleted from the new imposed contract. And the other interesting thing is that we're looking at prospective access, but anything retrospectively that might have been redacted does not get transferred to the new practice if a patient moves practice. And again, not relevant to prospective access, but does highlight issues around retrospective access, and this is obviously going to lead to retrospective access. And fundamentally, with all the changes and the mitigations, who is actually the data controller? Because actually it should be the GP practice. But the question that really arises, NHS England is now imposing a change, passing responsibility to the GP practice. And if that's the case, do we really have NHS England as the data controller? And if an issue arises, who is actually fundamentally responsible? Albeit, at the moment we haven't seen many issues arise. There have been a handful of issues, but it's something we need to be considerate to. So there have been lots of changes of the goalposts as I describe it, and I think we need to work with what do we have at the moment. So the message to ICBs that NHS England have sent down is that ICBs should be supporting practices to update their global configuration, and also supporting practices to resolve any bulk application of 104 codes that was made. And similarly to practices, there's been a communication out to practices to say, check your global settings and resolve any bulk codes. And there's a big document that references this as well. And when I looked at this document, one of the really interesting things here, and again, when I talk about change the goalpost, that they being NHS England have really tried to make it difficult for practices, I think, because there is the code, So if we're unclear about providing access to patients, practices can apply this code known as the 104 code to patients' records, and many patients have coded this across the patch to all their patients, and also informed their clinical system suppliers not to enable prospective record access. But one of the other things, if when I looked at the regulations and what they're doing at the moment, previously they said that actually when you enable prospective record access, if you've got a 104 code, those patients will still get access to their online records. What they've now done is that they've changed the rule set so that if patients have got a 104 code and they've got online access, when your practices go live, patients who've got online access and a 104 code will lose their online access, which is going to cause an issue. And it was not something that was initially in the plans, but has since come to light. And along with that change, NHS England have released a whole load of other SNOMED codes. And I find this really interesting as well, because we spent ages trying to get NHS England and EMIS and everyone else to give us codes that might be useful for our patients, and we're told it can't be done because there's no capacity. But as soon as something else needs to be coded, it seems to get priority. But anyway, that's another issue. So there are lots of other codes that have now been created that we could potentially use. So basically the question is, what do we do now, particularly if we've got a number of patients who have been coded with the 104 code because of the concern that was initially raised? So what I've done is that I've created a set of searches which I'll make available, and I'll send the link out later on. I'll add it to the chat so you can see what these searches are. And these are searches that I've written in EMIS. I've asked if anybody can convert them to System 1, and happy to circulate this to anyone who can. And what I've done here is done certain codes, certain searches with some certain actions. So if you download this set of searches, what you can see, I've labeled some with actions. And here, the first one that I'm going to look at is those patients who don't have any online access and don't have any prospective access code. And these are patients who haven't had any code applied for various reasons. And it could be those who are newly registered into the practice because they wouldn't have any codes from their previous practice. And essentially, these patients need a review of their records. So do these patients, are you happy for these patients to have automatic access to prospective access to their records? And you might find that's fine, and you can leave it at that. Or if you're unsure and you feel that you don't have the resources or process to review it, then do you want to consider just coding these patients with the 104 code? So that's the first search that's there as an action to review. The next one that I put down is these are patients who may require 106 code to apply, because these are patients who have current online access, and with the new changes that they've put in force, when your practice gets switched on, if and when at some point in the future, if they've got a 104 code, they will not have continued online access unless you then apply a 106 code. So these are patients with existing access to their records, and under the updated regulations, NHS England have asked EMIS to withhold their access overall. So the advice here is to look at this search, and all patients who have a 104 code and have current online access, we should just recode them with the 106 code to say that actually historically you would have made a decision to give them access. So let that cohort of patients continue to have access. The other bit here, so I've basically put in here, so from the early adopters sites, there's some amazing work being done by colleagues across the country who've looked at creating a search to identify those patients who may lack capacity, and therefore the advice from the pilot was to exclude these patients from automatic access. So what I've done here is I've linked the reference here, but you might want to code those that may lack capacity. So therefore there's an action here. So those patients who may lack capacity, who don't have any online access and don't have any prospective access code, do you want to review these patients and as the pilot suggests, code them as having the 104 code. Or there are some patients who may come up in that search who lack capacity, but you've already given online access to. And actually, there might be a cohort of patients that you feel the search may pick up as lacking capacity, but you've already given them online access. And if you want to continue for them to have online access, then just to code this cohort of patients with the 106 code. So there are some actions that we should take. I suspect the one that I'd really want practices to be mindful of is those patients who already have online access and who've been coded with 104. And the advice now is to code them with the 106 code as per this search, and hopefully that will help resolve those issues. The other thing I've put onto the bottom of the search is some information that certainly we found useful in our local area of those patients who have already got online access. So how many of your patients already have online access and are fully registered, or who've requested it but not using it? So there's some useful bit of information that you might find useful to discuss within your practices. And also what we found interesting was to find out of those how many have email addresses and how many have a mobile, so that we can send them messages through SMS. So just some searches there. And again, I'm quite open for people to comment if anybody wants to suggest some updates to this set of searches. I'm more than happy to update them and share them more widely. So I think just to summarize that, the focus here is that the goalposts have changed, because previously the 104 code was not going to affect previous access, but now the goalposts have changed to say that the 104 code is going to affect previous access. So that's one of the biggest updates that I think we just need to try and get across to practices, just to ensure that their patients are have continued access to what they've historically had. And then what I've looked to do is to put together a process for practices and for patients. And the first thing to say is that actually what have they said, and does it sound reasonable? And there's a one-off process that practices have to do. So in your clinical system, you have EMAS Manager, and the advice is to set that to a date from which retrospective record access is available to all patients. So the legislation is for prospective access, but the guidance is for retrospective access. So it makes you think, it makes you wonder where is the end game for this? It's basically all patients' record to be open, which I'm absolutely open for. I think all patients should have access to all their record, but this needs to be done in a controlled way, and the practices need to be in control. So the default that has been suggested by NHS England and also by EMIS is that you default this on your EMAS Manager to the 1st of January 1900 for every single one of your records, and it's a one-off process that you do on your EMAS Manager, and I'm generally supportive of that, although practices might want to decide internally at what date do they want retrospective access enabled, and that's a practice decision. The next bit that I suggest is that actually we set up a florey at the practice, and what this florey does, I'm going to talk about this a bit more in a bit, but essentially this is a florey that we've put together in North East London, and I'm grateful to my colleagues on supporting with this, but it's to help support practices engaging with their patients who request access, for them to do a bit of a questionnaire to ensure that they're aware of what that entails, and that is then confirmed by the patient and then documented in the notes. So you've got a clear description that the patients have agreed to essentially the terms and conditions of the practice in offering online access. And I think this is one of the strongest things, which if you look at a lot of people who've looked a lot into offering online access, what they've really said is that actually patients need to understand from a practice perspective what the deal is and the implications for this. And I think this is something that NHS England seems to have overlooked. The other thing within the practice is to ensure that all practices have a clear pathway. So if patients want a request for their online medical records, that they understand that this is done through a method, in North East London, the approach is that we encourage people to do this through the NHS app, mainly because we're implementing the NHS app across North East London to do lots of other things like online consultations and ordering repeat prescriptions. We're trying to do through one portal, the NHS app. And the other thing is to make sure that the process is clear to all practice staff, and ensuring that everyone knows what procedure you're using within your practice. And this should be for all staff, including locums. And it needs to be simple for that to occur. And the patient process needs to be very streamlined. So what I'm going to do now is go through a suggested patient process that you might want to share with your practice and see if this is something that would work for you, and also perhaps implement this on a dummy patient so that everybody can also look to implement. So this is the process. So the proposed process that we're looking at in North East London is this. So the first step is that the patient requests online access. So we're not doing this automatically. So we're saying actually we are not going to automatically sign off the EMIS request from NHS England to allow patients to have automatic access, and we'll wait to see what happens by the 31st of October. The rules might change again, so I think we just need to hold out rather than run the risk of implications that I personally feel will be greater for practices if they enable this right now. And if patients want online access, you deal with it on an individualized basis, much easier to manage, and practices would be in control. So when patients request the online access, what then should happen is that the practices will send out some information on what is it that happens when you request online access, and get practices to get a response from patients as well to say that yes, we agree with several features. What are those features? They're in the Florey, and you can download this Florey and use this in your own practice. But it's things like, patients will need to consider that actually there might be instances that you in your record that you might want to consider further, and are you happy for this when you gain access to online services? And it's your responsibility as a patient to ensure that the information is kept safe and secure, and sharing information is at your own risk, so that the practices have got some assurance that patients are aware of this. Do they understand that you might see some abnormal results or bad news in there? And patients again agree to the fact that that's what they agree to, and they agree that also understand that medical records are not always written with the patient in mind, and it's essentially primarily used by clinical professionals, but we do try to write it with patients in mind, but there might be some technical comments in there. And the records are about you, the patient, but errors do happen. And if there is anything that doesn't belong to the patient, they inform the surgery so they can be corrected, and that they're not being coerced into doing this, and that they are requesting the access alone, and that they agree to use the records responsibly and utilise the services appropriately. And if they agree to all of that, then that gets sent back to the practice, and the practice can then have that as a trail in the clinical record through the Florey. And the Florey, I'll circulate a link to how you can download that and utilise. And again, with these Accurx Floreys, you can amend them and tweak them if you want to for your own practice. So you send out the Florey to the patient. The patient will complete it and return it, and it's saved in the patient's notes. Some practices may want to verify the identity, and again, this is up to the practice to identify. If you're unsure about who is actually requesting access, you might want that patient, for example, to come into the practice to verify who they are if you've got any doubts. So that safety net, if you like, is in that process as well. Step 4 is then you just, if you agree, then as a practice, you just add a code to say that you verified the patient's data and code that. And then there's several things that can happen here. And the two things that may happen is that you might then decide, actually, I'll give the patient full prospective access, as their request, so full prospective access. Or you can say, actually, we're going to process this within a set time period, and give yourselves a time period of 2 weeks is the usual thing that we are recommending across North East London, where you have 2 weeks to review the record and potentially give the patient more than just prospective access, which is, in my view, much better to do. And then the final step is looking at the practice, reviewing the record within a set period, perhaps 2 weeks. And then in that time, other things can be done. You can make sure the problem list is sorted out properly, the medications are appropriately sorted out, and anything confidential is marked as such. So it gives the practice a lot more control over a process rather than automatically getting access to giving access to patients. So the take-home points really from this presentation is such: download the searches and review the codes, so the 104 and the 106 codes, and certainly with the 106 codes to apply those to the patients who've got online access and who have previously been given a 104 code. Download the Acrx Florey, and I'll circulate the link for that as well to utilise and implement the practice and patient process that I've outlined here, and certainly again share this with others and see what else we can do to update this, and I'll certainly be keen to learn from anyone else. You can see one of the points I'm not advising at the moment is for practices to sign up for the automatic access to happen before the 31st of October. I think things can change in the next 5 months, and we should see what happens, and we should try and err on the side of caution and just have processes in place so that we can manage our patients and then see if our unions and others can negotiate a more sensible thinking into NHS England. So I'm going to just stop there. So thank you all for listening. I'm going to go through the comments and questions. There's quite a lot that come through. I'll just open it up, but please put your hands up and ask questions, and we can go through this. I'm going to come off the presentation. Feel free to put your cameras on as well, so that I'm not just on my own. And then let's have a look. Can we have a telephone number? I think that's when the sound dropped off. Thank you for letting me know. So the link I'll put in to the chat in a bit, just so that you know where I've got the ability to download, where you can have the ability to download the searches and the Floreys. It'll be recorded, and we'll upload this as well. So the question: 104 coded patients will lose online access or just access to medical records? So anybody coded 104 would not be able to have access to their medical records. They'll still be able to do other things, but they won't be able to have access to the medical records unless you code them with the 106 code, which is what I'm suggesting on the searches. I'm not reassured that any of the issues that were raised last year have been addressed. Absolutely agree. I think what's happened is that nothing's changed. The contract's been imposed with some more, how can I put it mildly, radical changes. Don't know. Yeah, and the BMA, I understand, are in discussions with NHS England. Nothing's really come to light, but I suspect before October something will, and we just have to watch this space and see where we go with that. Really, download the Florey. I'll share that in a bit. The slides, I'll share a copy of the slides as well. Is it the requirement to check patient's ID? Good question, Nosheen. So there's never really been a contractual obligation to check patient's ID. It's very much if practices are unsure about who the patient is, then we should be checking IDs, and that goes with registration of patients as well. New patients, we don't necessarily, we are not border force, we are not checking patients' ID. But if we as a practice feel that we're unclear as to the person making the request to register or requesting online access, then we should be checking people's ID. So it might be, so for example, patients that I know who come to see me often, and I know exactly who they are, I will give them access without checking their ID because I can vouch for them. But otherwise, you'd probably want to have a process in your practice, depending on your practice population. There's some help as LMCs. I would certainly feel LMCs could help support the approach. There are some discussions going on with the BMA, and I think LMCs can help with trying to get the message out there. What I'm going to do is that I'll just I'll put the link in. What I've done this morning is that I've just summarized what I've talked about, and also put the links into a blog of mine. So I'll put that into the chat. So on the blog, you'll be able to download the searches and download the Accuex Florey as well. I've put a summary in there. So and if that could be circulated to other practices through LMCs and otherwise, I think it'll be good to get practices to do this in a unified approach, as we are doing in North East London. Avinash put down, are we any further with redactions being signposted by third-party software? I'm not convinced on this. My impression is that NHS England have removed it from the contract. So before, in 2020, they said that they would be providing redaction software. That's quietly been removed. So I suspect they quietly removing it has meant that they're no longer going to be providing it, and it's up to the practices to do it themselves, I suspect. And again, this could be something that could be challenged through the BMA, I suspect. Can parents have access to the children's record? Yes, is the answer. So there's proxy access. I haven't talked about proxy access. If you look further on the articles in the blog, I've written about proxy access as well. Generally, I think proxy access is good, and again, it could be used for example, patients, children who have who are on medications that you want patients to order for them, or they're getting clinic letters, and rather than providing a copy to the patient, they can look at the patient's the child's record and have access to them. So there might be a cohort of patients that you might want to provide proxy access to, not direct access, because proxy access will expire at 2 ages. At the age of 13, it gets removed and patients have to reapply for it, and at age 16, it gets removed again. So with proxy access, there is facility already that it basically gets automatically taken away, and then it needs to be reapplied for. So there are some safety nets built in, but that's certainly something we should be careful about. Prospective access, interestingly, is only for 16 plus. So prospective access isn't currently, the legislation isn't for children under 16. And the first 10 minutes, the recording, you will circulate the recording in due course as well. So that's the end of the comments in the chat. I'll open it up to any other comments or questions. Either pop your hand up or yeah, just put something in the chat. Or any thoughts, anything else you think we could or should be doing? Okay, so thank you, Selina. Sharon, so under 16s don't get previous access. So under 16s, if they've got proxy access at the age of 16, that automatically gets removed, and an email is sent out to the parent or whoever's got it to say that this is happening, and that they need to contact the practice to basically get access again. And then when they contact the practice, the process is, or I suspect should be the fact that the practice will then say, actually, does the parent need the access, or could the patient themselves have direct access, which is probably more applicable. But that's again on a case-by-case basis. And you might find actually some care homes, for example, have allowed all of their residents to have proxy access to staff members, so that staff can access order repeat prescriptions, for example. So there is a place for proxy access, but we need to be careful about how that's done. Could you advise about redaction software? There are loads out there. I don't know any particular one. If you've got one that you use commonly, I think the iGPR is one that people use quite often, and that's the one that I've certainly seen, but they offer some free packages as well, so that might be something to look at. But again, if we're looking at purchasing redaction software, that'll have to be done at practice PCN level. How much time the process review will take, e.g. searches, it depends how many patients you've got on your list. And generally speaking, the actions I've kept really brief, and actually what you could just do is any patients coming under that that search, you could just, the actions I've done so that you can just batch do to make it easier for you. So for example, patients who've had a 104 code and who've got current online access, patients who come up in that search, you can just batch code the 106, and that might be the quickest way to do it. What I'm not saying is activate your prospective access immediately, because I think that is something that we need to wait and see what NHS England say, because the contractual enforcement needs to be done by the ICBs. I'm not quite sure what measure that will take, and I think we just need to be measured in terms of how we respond. So if practices feel absolutely happy with it, absolutely go forward and agree to that email from EMIS, but I would just exercise some caution at the moment. Email the slides. What I'll do, I'll add the slides and the copy of this webinar to the blog that I've linked to. Do we have to give retrospective access to over 16s or prospective access? So the legislation is all about prospective access, so anything from today onwards or from a set day onwards. Retrospective access is absolutely up to the practice. My opinion is that if a patient requests access, we should have a process whereby we should try and give them all access, because otherwise they'll come back anyway to say, you know, I can't see this or that. So I'm very much in favour of all patients having access to their own records for various reasons. And if they do a SARS approach, you could just give them the access to their records as well, because that will deal with the SARS requests as well. But my view is that we should do this in a measured way, with the practice having control, rather than automatically access being granted to everyone on the list, particularly those who may lack capacity. And I think that's one of the things that has been mentioned but not highlighted by NHS England, and what the pilot practices really recommended. And again, that's something that hasn't been advertised very well. The checklist talks of policies. Are there any model policies out there? Really good question. Haven't really seen any model policies. That there is a plan to eventually put these together for North East London specifically. We've had to discuss this with our DPO, and it gets really complicated in terms of a template policy. But what I'm hoping to do is to get a model policy that we can agree within a few practices that we can then circulate to all practices. But yeah, the policies bit is again, we're committing ourselves by signing up to this that we've got all of these in order, and that is challenging. The go live date, as it stands, if your practice does nothing, the go live date is the 31st of October this year. But things can change, unless if you sign up, then your go live will be sooner. So if you signed up in the last month, your go live date will be tomorrow. If you haven't signed up, as it stands, it's the 31st of October, but I'm hoping things might change by then. From the early adopters, do we have insights into how long it takes to review each record and get it up to date? So the early adopters, they looked at redacting those who may lack capacity and then giving everybody else prospective access. That was the pilot early adopters. That's what they did. So they did not go through each individual record. My argument is that actually it's been in the contract for GP practices since 2019 to offer patients access to the online records if they want it. And my approach is we continue with that. So whatever we've been doing since 2019, we should continue with. Maybe within practices and post-COVID, everything's gone up in the air. So we should re-look at our processes. And what I've looked to do is come up with a process that gives us a bit of stability to actually have control, but have access that we can offer in a reasonable way. So I've put down 2 weeks for patients. So in our practice, we can turn that around in a few days. Some practices may want a bit longer. If you want to have it longer, then in your message out to patients, put it to 4 weeks. You can change it. So you as a practice can determine what you say to patients. Ginny, thanks. You use IGPR. I think a lot of practices do. Sabas, patients with mental illness or disorders, who wants the full access to their records and what is the best way to deal with that situation? So again, patients who have been coded with a mental health diagnosis, they will come up in the MAILAC capacity search. So if you download the search, you'll be able to see that's search, which was done by the BSW ICB. So credit goes to them because they were one of the early adopters for this, and they ran the searches. And what they did was that patients who had mental health codes or lack capacity codes, they basically excluded all of those patients. So that search I've copied into my set of searches. Anita's, can all formats of hospital letters be opened on the NHS app? So, okay, yeah, this is a specific North East London issue, I think, which might extend to others, where Kettering format documents cannot be opened by patients or anybody really, because they're clunky. There is a resolution in North East London. We've asked our trusts to stop sending things in Kettering format and to convert them to PDF. So that's the resolution that we've got in place that we're piloting at the moment separately. Maria, are the NHS app providing any additional support for patients accessing the records? So to be fair to the NHS app team, they have done their own little checklist. So when patients, and you could do this with a dummy patient, when you go into accessing your patient record through the NHS app, they do a little mini checklist themselves to say that there might be information in here that you might need to contact your practice about. So they do a bit of a checklist, but that's very much for the patient to see. The practices don't actually get confirmation that that's what the patients agreed with. And one of the other issues that we certainly have had in North East London is around third-party access, coercion, and I think we just need to be mindful of those patients as well. Shima, Practice Index have good policies, and I can see that you're in North East London. So if you have some good policies, are you able to share them, or can they be shared? I'm more than happy to add them to my blog, and we can have them, or we can review them as a North East London collaborative and recommended practices. If a deceased patient's family asked to print for the full medical record but don't have any power of attorneys, what will be the safety net? I think that's slightly different topic, but I think that's easy answer is discuss with your medical defence. I was going to say that because that's probably it's a whole discussion itself. Go live date, yeah, 31st of October currently. Can we restrict access to the comments section or free text on EMIS? Yes, you can't restrict access to certain sections. It's going to be free text or not free text. You can restrict it to. The prospective access is basically everything. So prospectively, from a day onwards, it's everything is accessible to the patient. So that's documents, free text, results, everything, unless you redact it. Unless it's redacted, patients will see it. So that is the way that the current legislation is working. And so that you can have individual practices. You can either do it at a practice level, you can stop it, but then you're going against the regulations, or you can do it by patient. So you could say, this patient I feel shouldn't have access to the free text, only has access to coded information. But again, you're doing that on a per patient basis, which is what we should be doing rather than globally allowing everybody access. Some thank yous. Thank you very much. We've been adding the 104 code from last year. How does this affect the practice? So if you've been adding the 104 code from last year, as I've highlighted in the searches, if you now search for those patients with a 104 code and have current online access, I think that's probably the big message, is that if they've got a 104 code and they've got online access currently, then those patients just apply a 106 code to them. And in the searches, I've highlighted that particular code, because I think that's been the change in goalposts, that NHS England have overtly done. How do we find the blog? I'll put it in the chat again, and I'll circulate it later on. We can get that circulated. Do you have to enter a date for access? So the date for access that's been recommended by NHS England and EMIS is the 1st of January 1900. And I think that's because they want retrospective access enabled at some point in the future as well, which is why they've suggested that. It's up to each practice as to what date they feel comfortable. But if it depends on how much you want to offer your patients. So, for example, in our practice, we want to offer everything to patients on a per patient basis. So therefore, a historical date doesn't matter. We'll set it to some time in the past. 1900 is fine on a global basis, as long as we retain control of doing the individual access. I think if automatic access is enabled retrospectively in future, then I suspect practices might want to change the settings they've got within their clinical system. But again, it's signing up by checking those boxes to enable prospective access through the email that NHS England and EMIS are sending out. Practices are committing to the fact that they have gone through consideration of all of those things and got mitigations in place, which is the issue that I have. I think as practices, we've been under immense pressure, and we've got enough to think about, and we should be having a process that's a lot fairer for patients. And if patients request it, yes, by all means, we should have a process. Automatically, I think that's in my opinion, it's overkill. Okay, I think that's summed up the comments. Any other final comments, questions, thoughts? Pop your hand up, type in the chat. Otherwise, more than happy for you to contact me. Otherwise, download the searches, download the Florey. If you've got any comments on any improvements, then more than happy to update those for everyone else to share. Mira.
Yeah, on the 3rd of May, we have gone live on all the patients' access. We have granted their access, including the free text from 3rd of May. Should we still add the code for 106 and 104?
Okay, so the thing is with if you've gone live, EMIS would have run the script on your practice. So if you've gone live, then you've gone live. You can't now, you can't go. If you apply the code, it's not going to make a difference because you've already gone live. So in effect, you've kind of missed the boat in that respect. And you could write to EMIS. I don't know if it'll work, but you could ask to EMIS, because you are the data controller, to say we do not want any further prospective access to be granted. There is a potential for you to code patients to withdraw access, but I think once you've gone over the bridge, I think it's really hard to come back, which I think is one of the issues really, which I'm not sure. Reading the legislation, I'm not sure what you can do, because once it's active, it's active, and unless you I think you just have to be really mindful now of everything that you're putting into the notes.
Absolutely,
patients can see prospectively.
Yeah, I have informed all the clinicians. Yes, okay.
Yeah.
So nothing, and we haven't breached anything, isn't it? We are still, we're in the right track, aren't we?
Yeah, so you're effectively doing what NHS England want you to do. But I think you've got to be, you're now in that state where you've got to be really mindful of what you're putting in prospectively, and you've got to ensure that you've got processes in place, which is fine. And I think if we look at up and down the country, that applies to 20% of practices. But with the other 80%, I'd probably be encouraging them to let's see what NHS England say by the end of October.
Right, perfect. Thank you very much. Yeah.
Thanks. Any other final comments or thoughts? Otherwise, I'll look to close. So thank you for Shan.
Yeah, it's just about the sensitive information. What do we do? Say someone is on safeguarding. If we put it on the free text, what do we do? How do we?
Hi, Mama, are you right?
Hi, yeah, thank you for calling.
Okay, no worries. Yeah, tell me, how are you? How was the weekend?
Okay. Oh, hi, Mira. Sorry, do you want to go on? Yeah. So if patients, so first of all, try and code those patients before your script is run on your practice to enable prospective access. So we should be running the search to add the 184 code to those patients. Once it's once they've had access, once prospective access has been granted, I'm just having a look at the codes now. If you want to withhold, the only code you can apply, there's a 109 code that you can apply that makes them unsuitable for prospective record access. What I don't know is whether that then takes away their prospective access. That's something that I'll have to test through. But there might be the way that if you've got patients on an individual basis, you can go into the clinical record and configure them on a individual basis. But I'm not quite sure. So what happens if patients have enabled? I'm not quite sure of what happens if you want to then withhold it. Because I think that's the bit that's unclear for me. But so that's why I'm saying do it before your script is run. So anybody who may have one of those codes in your practice, just code them with the 184 code now, so that you've already followed the procedure that was outlined by the early adopters. So that's, if you haven't done that already, just do that, and that's outlined in the searches that you can download.
Thank you, Osman.
Okay. But more than happy to, if you've got individual issues and we can run through it, just contact me. We can book a time in to go through. Good. So if there isn't anything else, what I'll do is I'll close the meeting, and hope that was useful, and feel free to contact me on anything else that you feel might be relevant. Thank you all very much.
Thank you. Bye.